blood pressure. And blood pressure is affected by primarily these two factors that are listed up on the board. And I am on page 111 of your 110 of your lecture notes. All right, so you already know all about cardiac output, right?
Okay.
Or you will in 2 days. What's another word or phrase we can use for blood pressure besides blood pressure? It also has pressure in it, but we're replacing the word blood. No?
Resistance?
No? What kind of fluid is blood primarily made up of?
Water?
Water. So blood pressure is also referred to as hydrostatic pressure. Okay? And though our atria and our ventricles contain blood, and that creates a force against them, usually when we talk about blood pressure, we're talking about the force exerted against the walls of a particular blood vessel. So if we draw that in cross-section, all right, we're talking about the force that's going to be stretching those walls out. And the two factors that primarily affect blood pressure are cardiac output and cardiac output is determined, what's our formula for cardiac output? Heart rate or stroke volume times the other one. So, heart rate times stroke volume. Okay? You know this already, right? So heart rate, then, what factors did we say affect heart rate?
Venous return? No, that's stroke.
That's stroke volume. So primarily, heart rate is affected by the autonomic nervous system. Okay, so we have sympathetic, or drugs that mimic the sympathetic nervous system are going to increase heart rate. And parasympathetic is going to decrease heart rate. Okay, we went through all the physiology of how that works. In addition, hormones and ions can increase heart rate. All right, so additional sodium ions will increase, additional calcium ions will increase, additional potassium will decrease. So thyroid hormone increases because it drives up the need for oxygen. Will also affect heart rate. Okay? So we've gone over all of this. This is just showing what your notes on that. All right, so stroke volume. What were the factors that affect stroke volume? And we had in the preload, which was essentially venous return. Okay, Starling's law and all that. Contractility. And when we talk about contractility, what is the major ion that we're talking about?
Calcium.
Calcium. And to some degree, afterload, or the pressure the heart has to work against to get blood out of the ventricles. Okay? And of course, sympathetic nervous system can affect calcium as well. But these are what we covered in those aspects. All right? So cardiac output, and we talked about, these are all slides that we saw under those components. All right, so just a bit of review. An increase in end-diastolic volume would do what to stroke volume? End-diastolic volume is
Before
higher or lower than end-systolic volume?
Higher.
Higher. So if we had a higher end-diastolic volume, Darling's law said that would say that our stroke volume, due to increased contractility, would be higher as well. Okay? Now, if we had a higher end diastolic volume, just looking strictly at increased venous return, it would increase stroke volume. What would happen to end systolic volume? All right, let me draw it out. So here we're doing ventricular filling. There would be normal. Then we would have ventricular contraction, and we would have stroke volume. Okay? Let's say that for whatever reason we have a higher in diastolic volume. What would happen to our end systolic volume? Stay the same. Because the greater force of contraction is going to increase stroke volume, but we're going to come back to our normal volume. Okay? All right, increasing skeletal muscle contractility in the legs would do what to cardiac output?
It's going to increase venous return.
There you go. And increasing venous return is going to increase stroke volume. And increasing stroke volume would increase cardiac output. Okay, that's how I want you to think about the question for the exam on Thursday. What I don't want you to do is think of compensation. So normally, if we increase stroke volume, heart rate can go down and maintain the same cardiac output or vice versa. I want you to do a direct effect rather than over time, the heart would, as you strengthen your stroke volume, the heart doesn't have to contract as much and heart rate goes down and cardiac output stays the same. So I want you to think of a direct effect. If heart rate goes up, cardiac output goes up. If stroke volume goes down, cardiac output goes down, okay? Without looking at what might happen down the line as the heart becomes more or less efficient. All right, so when we look at the blood flow through the body, we start out with a single aorta, and then we form our small arteries and arterioles, and we get to capillaries, and then the capillaries come back and join up again. So if you think of this as a river flowing into several smaller rivers and creeks and then rejoining again, the velocity is going to decrease as we get multiple smaller branches, right? The speed of the blood flow is going to decrease, which makes it advantageous in the capillaries because as the blood is flowing more slowly, there's a greater rate of exchange. All right, we talked about that a little bit. What happens to surface area? The volume right here is what in the relationship to the volume right here? Exactly the same. More surface area, but same volume, okay? So then the pressure with more surface area resistance is going to, in any particular component, we're going to see a change in overall pressure is going to drop because we're moving farther away from the heart. The blood flow is slower, okay? But in these vessels right here in the arterioles, we have the greatest effect in changing the blood vessel diameter and in changing pressure. So this diagram is at the bottom of page 110 of your lecture notes. And before we look at that, let me just go back to this slide right here. Okay. Peripheral resistance, we've talked about cardiac output. So the other factor that affects blood pressure is peripheral resistance, and that has to do with our blood vessels. Okay? Cardiovascular, heart, blood vessels. So this is what we're going to finish up talking about with blood pressure is the change in blood vessels. Cardiac output we've covered already, and I just reviewed those factors with you briefly. But the rest of the discussion here is going to be on the peripheral resistance primarily. So if we look at this diagram in your lecture notes of blood pressure, you can see that overall blood pressure decreases. That's what allows blood to flow. On the proximal side of the arteries, I'm going to open too long. On the proximal side of the arteries, we see this okay? Why do we have this change here and not here? This change is the reason why we have a pulse. Do we feel a pulse in the veins? No. With every stroke volume, there is an ejection of a volume of blood into the arteries, and they expand and then recoil. Once we're past the capillaries or into the capillaries, we just see a constant drop in pressure, but we don't see an expansion and a recoil. So the veins don't have a pulse. A pressure, yes, but not a pulse. Is there a question or comment? All right, so this highest amount of pressure during ventricular ejection is identified as systolic pressure. When the ventricles are in systole. When the heart is in diastole and neither atria nor ventricles are contracting, we have diastolic pressure. All right, so if this was 125 and this was 80, average blood pressure, all right, would be a line right through the middle. So that would be average blood pressure, where we take 125 plus 80 and divide by 2, and our average blood pressure would be 102.5 millimeters of mercury. But that's not an accurate view of the overall blood pressure of the cardiovascular system. Because if we look at our ECG, for the most part, is the heart in diastole or in systole more? Time-wise. In diastole, unless you're exercising or something. So we have the heart at rest for a longer period of time than the heart is at work. So blood pressure is actually going to be closer, overall blood pressure is going to be closer to the at-rest blood pressure than to the systolic pressure. And so we use the term mean arterial pressure. We talked about this a little bit earlier. So when you take the mean of something, it's the number of times a number appears within a given group, rather than the sum of all of them divided by the number of. So if I had scores on a quiz, all right, and the scores on the quiz were 4, 5, 8, 8, 8, 7, 8, and 9, the average would be all of these numbers divided by 1, 2, the sum of all these numbers divided 1, 2, 3, 4, 5, 6, 7, 8. Okay? Let's say I had a 0 and a 1. Now, that's going to lower my average, the 0 and the 1, right? But the closer, I had a lot of people with A's and 8s and 9s. And so the mean would be higher than the average, because I have more of these numbers occurring. So a mean takes into account the number of times a particular value is present. All right? So when I give my students, the students at Sac State are always wanting to know what was the class average? That doesn't mean anything to me, because I'll have about 20% of the students will get in the 40s and 50s. And I'll have more students, not more numbers, but I'll have 80s and 90s and even over 100% to show there were actually people that could do that well. But I have a bunch of students that their parents are paying their tuition. I'm not sure exactly what the reason is. The average over there is much lower than it is over here. And when I average it out, that brings the overall class average down when I only have a few of those, and the others are actually, the mean would be higher because I have more of those numbers. Okay, so when we talk about the mean arterial pressure, because the heart is at rest longer than it is at work, our mean arterial pressure is actually closer to diastolic. So you can see the line right here. See, it's below average. So mean arterial pressure is determined by following formula. It's in your lecture notes. it is equal to diastolic pressure plus 1/3 of pulse pressure. And pulse pressure is defined as the difference between these two numbers. So pulse pressure is equal to systolic minus diastolic. Okay? So I don't add these two together and divide by 3. I find my pulse pressure, divide by 3, and add it to diastolic. So if I take these values, 125 minus 80 is 45. 45 would be my pulse pressure. All right, so in our example, we would have 125 minus 80. Pulse pressure would be 45. 1/3 of that would be equal to 15. So 80 plus 15 gives me a mean arterial pressure of 95. And that's lower than my average blood pressure of 102.5 because the heart is at rest longer than it is at systole.
Where did you get the pulse pressure again?
Pulse pressure is the difference between systolic and diastolic. Okay. Pulse deficit, as you'll do in lab, is the difference, if there is any, between apical pulse and radial pulse. That's pulse deficit. The pulse pressure is the difference between systolic and diastolic pressure. Okay? All right, you have this diagram on page 112, but it doesn't have any arrows in it. So let me turn the lights off and show you where the arrows go. 2/3 of the material on this concept map is cardiac output, which we've already covered. So down here, this is factors that result in increased mean arterial pressure. One is cardiac output. The other is peripheral resistance. Those two phrases I put at the very beginning. So cardiac output, draw a line from cardiac output and join it with a line from increased peripheral resistance, and both of those are going to result in increased mean arterial pressure. Okay? So a line from here and a line from here is going to be increased mean arterial pressure or increased blood pressure. Now, factors that affect cardiac output. Heart rate. Draw a line from heart rate to cardiac output. And stroke volume. Draw a line from stroke volume to cardiac output. Again, this is a review. We've covered this a couple of times already. All right? So increased heart rate increases cardiac output, increased stroke volume increases cardiac output. All right? So now what factors affect heart rate? Increased sympathetic activity is going to cause increased heart rate and increased contractile force. Hopefully that's familiar to you already. Okay, so draw an arrow from here to these two factors. Increased force of contraction is going to result in increased stroke volume. So draw an arrow from here to here and an arrow from here to here. So increased sympathetic activity is going to affect both heart rate and stroke volume. Okay? And then these factors, a low blood pressure, elevated levels of carbon dioxide, low levels of oxygen, are factors that are going to turn on the sympathetic nervous system. So draw an arrow from here to here. All right, so starting at the top now, decreased blood pressure, decreased pH, draw an arrow from here to here. It's going to increase sympathetic activity. Draw an arrow from here to here and here to here, because increased sympathetic activity is going to increase heart rate, and increased sympathetic activity is going to increase ventricular force of contraction. Okay? So all that changes heart rate. All right, now increased blood volume. Exercise is going to increase venous return. Draw an arrow down from here to here. Increased venous return increases in diastolic volume and preload. Draw an arrow from here to here. That causes an increase in the force of contraction, Starling's law. Again, this is a summary of what we've already covered. And then that plus sympathetic increased force of contraction due to calcium ions is going to result in an increased stroke volume. So this whole aspect here, dealing with increased cardiac output, we've covered. Then increased vasoconstriction is going to increase peripheral resistance, and that's the other factor, okay, dealing with blood vessels that we're going to look at. Does everybody have those connecting lines? So this image is just the same thing, just a little larger picture, okay? So here's the decreased blood pressure, decreased blood pH, increased blood carbon dioxide, all of that. It's just showing the same side of this aspect, okay? So in the interest of time, I'm not going to go over that stuff we've already talked about. So blood vessels on the cardiovascular side, again, a decrease in blood vessel diameter increases vasoconstriction in a factor of 4, all right? So if we decrease the blood vessel diameter by half, we double the peripheral resistance. So which of these, looking primarily with those two factors then, all of the following, an increase in all of the following except one would cause an increase in blood pressure. That would cause a decrease. So what is the one factor listed up there that if we increased it would cause blood pressure to fall or to become lower? The radius of the arterioles, okay? So if we increase fluid retention in the body, that's going to increase venous return. If we increase stroke volume, that's going to increase cardiac output. Viscosity of blood vessels and total number of blood vessels increase peripheral resistance, and we're going to talk about that in just a moment. So increasing the radius of the arterioles decreases peripheral resistance and lowers blood pressure, okay? All right. This morning's class asked me not to change the questions too fast, so some of you are writing this down. I'll wait a little bit longer. But it should make logical sense, okay? Well, we haven't talked about the three factors that specifically affect peripheral resistance, but they're right here. I'm going to talk about them in just a moment.
Which slide before the slide though, it was if you decrease the blood vessel by half?
It increases the peripheral resistance by a factor of 4. All right, so these are the three factors affecting blood resistance. So you can see them right here. Radius of the arterioles, viscosity or thickness of the blood, and total number of blood vessels. So skip page 114 and turn to page 116. We'll come back to 114 at last time. So the two major things that affected blood pressure were cardiac output and peripheral resistance, and these are the three things that affect peripheral resistance. All right, blood vessel diameter. Again, that has to do, if we have a vessel that looks like this and a vessel that looks like this, fluid flowing through that vessel in what we call laminar flow isn't going to bump against the sides of the vessels. It's going to flow more smoothly. Along the sides of the vessels, it's going to create turbulence where the water molecules, and in the case of blood, the blood cells, will bump against the vessel wall and create turbulence. In a smaller blood vessel, more of a greater proportion of the volume of that blood is going to end up contacting the blood vessel wall. So that's why increasing the diameter or decreasing the diameter of the blood vessel wall affects peripheral resistance. Because when we decrease the diameter, a greater number of the molecules in the blood end up bumping against the vessel wall, all right? What part of the autonomic nervous system primarily changes blood vessel diameter? Sympathetic. Okay, the only place where parasympathetic does that is in the erectile tissue, so the penis and the clitoris structures. All right, so sympathetic, if we increase activity, increase the amount of norepinephrine released, it's going to cause constriction of arterioles primarily. And if we decrease activity, it's going to cause dilation. So in our fight or flight response, we have both. Peripheral arterioles in the skin, people go white, okay, when they're being stimulated by the sympathetic activity. So peripheral arterioles in the skin are going to constrict. Blood supply to your digestive organs and other viscera is going to constrict. But what major tissue is going to dilate? Think of the fight or flight. Skeletal muscle, okay? So peripheral arterioles skin and digestive organs, along with our other organs, but most of the blood supply is in the digestive organs, will constrict. Skeletal muscles will dilate. But the overall effect is an increase in blood pressure due to these two. Okay. Now we do have some hormones that we'll discuss primarily when we get to the urinary system that will also cause vasoconstriction. Okay. But primarily it's our autonomic nervous system. Then the other factor is the length of the total length of blood vessels in the body. Now this is not something that we can just change in a couple of seconds or even in a week. Our body can't decide blood pressure is too high, therefore I'm going to eliminate half of the blood vessels in the body for a period of time. This has to do with body mass. Okay? And adipose tissue has a greater number of blood vessel supply than skeletal tissue does. So if someone is overweight and has high blood pressure, that's going to be one of the things that the physicians are going to say is you need to get rid of some of that, make the adipose cells smaller, and therefore you won't need as many blood vessels. It doesn't always correlate that way. My dad is 6'3" and weighs probably 185 pounds. My mom is 5'7" and probably weighs 250. Guess who has the high blood pressure? My dad. My mom's blood pressure is perfectly fine. All right, she has some type 2 diabetes, but not serious. It's not really affecting her health. And so my dad and his mother had to take blood pressure medications. If the cause of high blood pressure is not known, you can't say it's because of this disease, because of kidney disease or arteriosclerosis or whatever. It's called primary hypertension. Okay? And if the cause is known, then it's called secondary hypertension. So with primary hypertension, there's no condition that's known to cause it. So there's no condition to get rid of it. You might just have to take medication that dilates blood vessels, that lowers cardiac output, and helps to decrease some of the factors that affect blood pressure. Okay? So this is one that's really difficult to change, blood vessel length. Viscosity has to do with the thickness of blood. And we'll learn these numbers in our next unit, so don't feel like you have to memorize them. But we can determine the proportion of blood cells to fluid by taking a sample of blood and spinning it in a centrifuge, and the heavier elements, the cells, will settle to the bottom. And so when we look at the ratio of blood to plasma, which is the fluid, typically 45% of the blood by volume, not weight, is cells, and 55% by volume is plasma. Now that's gonna change. Females are normally 38 to 42, and guys 46 to 52. Why do you think guys are higher? Why would they have a higher ratio of blood cells to blood volume?
Maybe because they're more muscular.
Yeah, exactly. They have more skeletal muscle, therefore they have a greater oxygen demand and need more red blood cells to transport that oxygen, all right? Now, any factor that's going to change this ratio is going to change viscosity.
Does it technically mean that females are more like susceptible to higher blood pressure since we have more fat?
Not necessarily. All right, so if we increase the ratio, we have more cells. We can do that by increasing cells or by changing fluid, all right? So we can affect cells by living at a high altitude. And that's going to stimulate a hormone to be released to cause your body to make more red blood cells. Blood doping. That's easily detected, but everybody in the cycling world has been accused of it. Basically what cyclists or other athletes do is take out their own blood several months before a race or some athletic event, spin it down so they get rid of the extra fluid volume, and then the night before or a few hours before an event, usually helps to do it maybe 12 to 24 hours before the event, inject the blood cells back into their bodies, and now they've got increased amount of blood cells, increased amount of ability to carry oxygen. Okay, but it's going to give them a higher hematocrit, so it's easily tested. And in the cycling world, the winner of the race automatically gets tested, and then the others, competitors, randomly.
Where do they get something like that done? Who does that? Where do they do that?
They'll do it in the back room of a hotel.
Pull their own blood out.
They have,
They have a centrifuge machine.
Not that
they're
complex.
not that complicated. They've got doctors traveling with the team.
Wow.
Yeah.
So
So there have been stories, you know, with Armstrong and a bunch of people lying down the back of the bus and people saying that this has happened, you know, and getting blood. They all have to be as a refrigerator to carry the blood and stuff with them. So I'm not saying I believe it happened. I mean, there's plenty of people who have testified it happens, and there's plenty of denials that go along. So, like I said, Armstrong with all of his, how many now is it, 8 wins? Whatever. As a winner, had to have been tested after each one. So, anyway. Because living in a high with blood doping, even an infant held below the mother's heart for a few minutes after birth is going to get more of the mother's blood and have a higher number of blood cells, okay, which is going to thicken the blood. Now, the other thing we can do is the fluid. So anything that's going to add or remove fluid is going to change the ratio as well, all right? So diuretics, drugs that cause you to go to the bathroom more often and lose fluid that way. Drinking water. Drinking alcohol, which affects the hormone we'll talk about later. Okay. Perspiration, I said sweating this morning. I'll use a nicer word this afternoon. So you're losing or gaining fluid without changing the number of blood cells. What about hemorrhaging? Let's say you have a splitting aneurysm, aortic abdominal aneurysm, and you're leaking blood into your abdominal cavity. That's certainly going to lower blood volume, but is it going to change viscosity? No, because you're losing fluid and cells at the same time. So when we change viscosity, it has to be a difference in the proportion of those. Okay?
So when these people have died from water poisoning, is that directly related to this here, to the viscosity?
Yes, but it's more directly affected to the size of the cells in the brain.
Oh, okay.
Because with high levels of fluid, it causes the cells to swell. And it certainly affects the heart's function because it's going to dilute the ions.
Okay.
It's going to make hypokalemia and natremia and all of that. That's more important than the actual viscosity. But certainly if you do blood doping, it's going to increase the work of the heart because it's going to be thicker blood that has to pump through.
So for the blood doping, you said they take out the blood a few months before the event?
Well, you don't want to, if you take it out a week before,
Oh.
that usually doesn't give enough time for the body to replace it. And what you're trying to do is add to that amount. So the body has the opportunity to replace it, and then you're adding those cells back on top of that. So you would have your normal amount of red blood cells, and then you're adding even more.
So like a blood thinner, would that decrease?
That's a wrong word. Aspirin is, it's a misnomer. Aspirin is called a blood thinner. It doesn't really thin the blood by changing the number of red blood cells or the amount of volume. What it does is it inhibits enzymes in the platelets from making them sticky and causing the blood to thicken, as in a clot where we have protein threads that trap, like Jello thickens and doesn't flow anymore. So it's really not because we lost water when Jello thickens. It becomes thicker because protein filaments have formed and trap the water so it doesn't flow.
Is that what Coumadin does too?
Yeah. So what we're talking about with blood thinners is not so much the ratio of cells to fluid as affecting platelet or clot formation. Okay? And it appears to thicken the blood because it doesn't flow as easily or it flows more easily, but it's from a different
So with the
cause.
platelets not sticking together, would that still affect velocity?
No, because the same number of cells are there. It's just platelets sticking together can be a factor that triggers those filaments forming and trapping water so that it doesn't flow. And in a week, we'll talk about that.
Okay.
Okay? Or 10 days. All right, so on your, in your lecture notes, there is a table of chemicals that affect blood flow on page 116. Really, the only one that's new information is that top square, where it says increased vasodilator substances such as carbon dioxide, lactic acid, or this is a chemical from the cells that line the blood vessels. That's the only one that's new information that you need to worry about. So, and we've talked about, this is just increased carbon dioxide. It's because the tissues are using up the oxygen. So in response to that, our precapillary sphincters dilate and we get more blood flow to a particular tissue. Okay? So the only really new